Hello viewers, me Dr. Sanjay Prasad Gupta, a consultant gynecologist. Today's topic of discussion is menopause. Introduction. Permanent cessation of menstruation due to ovarian failure is termed as menopause. When there is cessation of menstruation or no menses following final menstrual period, then we call menopause has set in, which is evidenced by high levels of FSH and LH with low levels of serum estradiol. Now, menopause do not suffer from a disease, especially a estrogen deficient disease as we usually think of, and menopausal hormone therapy should be considered as treatment of symptoms in the short term and a preventive pharmacology in the long term. Menopause should not be perceived as a signal of impending decline, but it should be welcomed as a new chapter in women's life and better prevented or better planned for a good well being and optimum health in the years ahead. The negative mental thoughts, which is usually blamed to menopausal symptoms, is not justified, and it may be due to life events that occur at that middle age of menopausal age. Now, the usual age of menopause or the average age of menopause is 51 to 52 years, but Indian women go for earlier menopause, and that is 46.2 years. Now the age range is 40 to 58 years. Now as the expectancy of life is increasing, so the woman will be living longer, which is deprived of estrogen and with the symptoms of estrogen deprivation. So, we should consider and we should plan the next life in a better way. Now, premature ovarian insufficiency. When there is menopause before the age of 40, then we call it premature ovarian insufficiency. Now, the causes of premature ovarian insufficiency are toxic exposure, infection, radiotherapy, chemotherapy, hysterectomy followed by bilateral salpingo-oophorectomy, ovarian surgery, Turner's mosaic karyotype, fragile X syndrome premutation. All this can lead to premature menopause. Now, if there is estrogen deficiency, then there is central obesity, endothelial dysfunction, decreased HDL, and depression. All this can lead to premature menopause and ultimately premenopausal atherosclerosis, which can increase the risk of cardiovascular diseases. So, HRT is must in premature menopausal age group. Now, the guidelines for salpingo-oophorectomy. When a uterus is being removed for benign diseases, then up to the age of 45 and even up to the age of 50, the bilateral ovaries are preserved. Now, if at all the ovaries has to be removed before the age of 45 or 40, then HRT has to be instituted in that case, because estrogen acts as a primary prevention. It acts on brain, heart, bone, lipid, endothelium, and other tissues, preferably if they are not defective. So, estrogen is used for primary prevention and not for the secondary prevention, and it has to be started as early as possible, preferably just after surgical menopause. And if there is natural menopause, then when the symptoms starts, then delaying it, and especially it has to be started just after menopause or within 10 years of menopause and not beyond that, because if already brain and heart tissue is affected, then it could be detrimental, as per the studies has proven. Now, prevention of diseases. Disease is something best treated not by medication or by surgery, but by prevention. The health program should be evaluated in terms of years free of disability rather than mortality. Prevention of disease means compression of morbidity. So, menopause or menopausal transition age group should be considered as an opportunity for the prevention of diseases, early detection of the diseases, and if it is detected, for the treatment of the diseases. Now, the preventive issues which is necessary at the time of menopausal transition or postmenopausal age group. First thing is family planning. They also need to consider their family planning. What are the contraception based suited for them, and whether they should consider further reproduction or not. Next is cessation of smoking. If they are addicted to smoking, then this is the high time to stop the smoking to prevent further diseases. Next is cancer screening program. Every menopausal woman should go for the cancer screening, such as the cervical cancer screening, for such as pap smear cytology, HPV DNA testing, or VIA. Next is breast screening program for breast cancer screening. Here, as per the requirement, USG, digital mammography, or chest mammography has to be done, which has to be started after the age of 40. Now, even the pelvic examination and ultrasonography has to be done to rule out ovarian or endometrial neoplasia. Next is the stool for occult blood testing has to be done after the age of 50 at every 10 years intervals. Now, colonoscopy is also indicated after the age of 50 every 10 years after up to the age of 75. Next is hypertension. Now, after the age of menopause or in the menopausal age group, every woman should be checked for BP measurement periodically and to detect the hypertension. Similarly, periodically sugar testing has to be done to detect the diabetes mellitus. Similarly, periodically lipid profile has to be checked and statin group of drugs has to be started for to reduce the atherosclerosis and coronary artery disease. Similarly, cardiac markers has to be checked to prevent cardiological diseases in the future, such as CRP and calcium deposition in the coronary artery, that is computed tomography, where preclinical plaques can be detected, and if required echosprin can be started. Similarly, body weight, which is very important, and as per the BMI, if required, body weight has to be reduced by adequate nutritional diet and physical activity and exercises. Similarly, alcohol, drug, all to be reduced. Then uh, there is certain immunizations which is needed in that particular age group, such as COVID-19 vaccination, flu virus vaccination after the age of 65, respiratory syncytial virus vaccination after the age of 60, herpes zoster vaccination 2 doses after the age of 50, pneumococcal vaccination which has to be repeated every 10 years. So all these immunization program has to be considered. Next, if there is any mental issues, if there is any sexual problem, if there is any parental issues, if there is any marital issues, all those things has to be discussed and should be treated as per the requirement. Similarly, the process of osteoporosis, which occurs usually after the age of menopause only. Usually the saying is, we all come in this world through brim of pelvis and we go from this world through neck of the femur. So osteoporosis prevention is equally important, and it has to be started from the age of adolescent, because that is the time where maximum bone density accrual occurs, and during that time calcium supplementation is very much needed, and calcium supplementation is also needed during pregnancy and breastfeeding, and calcium supplementation has to be given in middle age group who are deficient in diet or who are not able to take adequate calcium and vitamin D from the diet, or if there is associated risk factor for the osteoporosis. And in those women, calcium and vitamin D has to be supplemented to prevent the process of osteoporosis. And osteoporosis, why it occurs in the menopausal age group? Because of decrease in estrogen, decrease in calcium, decrease in vitamin D. So periodic checkup of calcium and vitamin D is also required in those age group, because in those age group mostly they go from in indoor life and then reduced sun exposure, deficient diet, sunscreen use, if there is risk factors for osteoporosis, and even they can go for bone mass density measurement by DEXA, and accordingly measurement of vitamin D3 in the serum, and then therapeutic use or preventive use of vitamin D can be started along with the calcium. Now the problems and diseases. Now the problems can be categorized in three categories. Number one, when there is relative excess of estrogen, which can cause abnormal uterine bleeding, endometrial hyperplasia, or endometrial carcinoma. Or category 2, which is because of the estrogen deficiency, which can present as genitourinary syndrome of menopause, such as urgency, frequency, recurrent UTI, irritation, burning, dyspareunia, or in terms of osteoporosis, which can lead to bone fracture. Now, the category 3 is the signs and symptoms due to HRT itself. Now, when there is relative excess of estrogen, in those cases, women present with abnormal uterine bleeding, and in that case, we should rule out endometrial neoplasia, endometrial pregnancy, and extrauterine causes of bleeding. So, a physical examination, proper history, and endometrial assessment has to be taken. Now, in the postmenopausal age group, when the endometrial thickness is less than 5 mm, endometrial biopsy is not required. In the premenopausal age group, when the endometrial thickness is normal, that is 12 millimeter, but there is risk factor for the neoplasia, such as prolonged exposure to estrogen or prolonged history of amenorrhea or oligomenorrhea, or there are associated high risk factors such as obesity, hypertension, diabetes, or dyslipidemia, then endometrial biopsy has to be done even if the thickness is normal. But if the endometrial thickness is above 12 millimeter and there is no symptoms, then also endometrial biopsy has to be done. So endometrial assessment has to be done by USG by seeing the endometrial thickness, and if required by endometrial biopsy, or saline hysterography can also be done to rule out endometrial polyp or submucous fibroid, or direct hysteroscopy can also be done to rule out intrauterine pathology. And at the same time, if required, if there is any vulval, vaginal or cervical disease which has to be ruled out. Cervical disease can be ruled out by visual inspection, by pap smear cytology, or if required colposcopy and colposcopy directed biopsy. So if there is any organic disease found, then we can go for total hysterectomy, whatever route possible. And if there is no organic disease and it comes to be endometrial hyperplasia, and if the uterus has to be preserved, then we can go for progesterone therapy in the form of medroxyprogesterone acetate, megestrol acetate, or levonorgestrel intrauterine inserts. Now, if the uterus is need not to be preserved, then hysterectomy can be considered, and if there is progression of neoplasia in the follow-up or in the surveillance, then also hysterectomy has to be considered. Now, if there is no neoplastic disorder, then for the regularization of the diseases and for the treatment of early menopausal symptoms, we can start with low dose oral contraceptive also, which can act as HRT as well. Now, next is the estrogen deprivation syndrome, that is genitourinary syndrome of menopause. This is best treated by vaginal cream. For the first 2 weeks, it is used daily, and after that, twice weekly. And in here, ospemifene 60 milligram, which is selective estrogen receptor modulator, can also be used. Next is the if there is symptoms of libido or loss of libido, or there is mood upset, then tibolon can be started from the low dose, that is 1.25 daily, and it has to be started 1 year after the menopause. Now, if there is osteoporosis, then in that case also HRT or other osteoporosis related drugs such as biphosphonate, raloxifene or tripartite can be started along with vitamin D and calcium supplementation. Now, hormone replacement therapy. Hormone replacement therapy, usually we can go for continuous regimen or sequential regimen, and if the uterus is intact, then we have to go with estrogen and along with progesterone, which has to be supplemented. Now, the early younger age group, the sequential group regimen is preferred, because if here we go for the combined continuous regimen, then there are chances of breakthrough bleeding. So usually the estrogen therapy is started in a low dose, that is 0.3 milligram, then 0.4 milligram, and then if symptoms are still persisting, then we can increase to 0.625 milligram. And if progesterone has to be supplemented, then in the terms of medroxyprogesterone, norethisterone acetate, levonorgestrel intrauterine insert, or dydrogesterone, Dionogest, drospirenone, all can be used. But here in India, only dydrogesterone is available or micronized progesterone is available. So dydrogesterone, if used continuously, then 5 milligram, or if used sequentially, then 10 milligram can be used for the next 12 or 15 days of the other half of cycle. Now, if micronized progesterone is used, then for continuous therapy 100 milligram, and for sequential regimen for the next 12 to 15 days of cycle, 200 milligram of micronized progesterone can be used. Now, as I said earlier, for the genitourinary syndrome of menopause, the best form of therapy is vaginal cream topically, which has to be used. Now, if Tibolon is used, then it has to be started from the from 1.25, and if required can be increased to 2.5. Now, for genitourinary syndrome of menopause, ospemifene can also be used, which is third generation SHAM. Now, if for vasomotor symptoms, also HRT is preferable, but if it is contraindicated, then selective serotonin reuptake inhibitors, paroxetine, or sleep uh, inducers can be used, and sometimes vitamin E, which acts as a placebo, can be given. Now, for osteoporosis also HRT can be used along with calcium and vitamin D supplementation. Now, to conclude, Indian woman goes for the menopause earlier, that is 46 years of age, and as they live longer, they suffer from estrogen deprivation for a longer duration. And most effective treatment of vasomotor symptoms, genitourinary syndrome of menopause, and prevention and treatment of osteoporosis is menopausal hormonal therapy. Menopausal hormone therapy should be given as continuous or sequential, and if the uterus is intact, then the conventional therapy is estrogen along with progesterone. But if there is no uterus, then estrogen only is used. Now, when there is local symptoms, that is genitourinary syndromes of menopause, then local therapy is preferred in the form of vaginal cream. When there is symptoms of libido and mood, then Tibolon is preferred. Now, the which drug has to be given, or what should be the dose, or what should be the route of administration, and how long, the duration of the treatment has to be considered and has to be individualized based on the age of the patient, symptoms of the patient, and the risk factor associated with the patient. And initially at 6-month duration, and then annually it has to be checked and re-evaluated periodically whether it should be continued or stopped. Thanks for watching my video. Do subscribe my channel for watching similar types of video in future. Jai Hind.